Y'all remember last episode where I might have briefly mentioned Bayesian analysis in passing? You know, when we were talking about calcium pretreatment before DILT for AFib? I mean, I barely even said the word Bayes, so you probably don't even remember it at all. But because I don't want to deprive y'all of an opportunity to hear more about research methodology, this is a nerdy podcast after all, so I'm assuming a certain line of baseline nerdery here. I want to dig in a bit more on how to interpret the results of a Bayesian analysis. Now, because I spent most of last night in a deep rabbit hole trying to learn it myself, I want to share what I learned. Now, for those actual methodologists out there, please feel free to drop me an email telling me I'm an ignorant slut and I need to stay in my own damn lane. I'm an EMS doc after all, and I am absolutely used to hearing it. Y'all probably know I'm also an airway nerd. I found the perfect paper to talk about airway and Bayesian nerdery. Okay, well, actually, Mikey V found it, and he sent it to me. It seems like our buddy Mikey is happily back at home in Oregon and has been getting some questions about his folks about whether we ought to be given the paralytic before the sedative when doing RSI. This is something a lot of people call paralytic first intubation, and it seems to be making the rounds of the FOAMed world. So it seemed kind of like a cool paper that involves a Bayesian approach to answering a clinical question. Now, I think that's just about perfect. We're, of course, going to talk about the paper, what they did, what they found, and how I think it should impact our clinical practice. But we're also going to dig into how they report the results. They use something called a 95% credible interval instead of the 95% confident intervals that we normally read about. They kind of look the same, but it turns out we really should be careful not to interpret them in the same way. So we're going to cover the differences in these things. Now, I know all of that talk about credible intervals has you nerds on the edge of your seat, so now really is not the time to switch over to those bums at the EMS show. Stick around, we'll be right back.
Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. All right, no more ado. Let's jump right into the paper for this episode. The title is The Effect of Administrative Sequence of Induction Agents on First Attempt Failure During Emergency Intubation. It's a Bayesian analysis of a prospective cohort. The authors are Drs. Catoire, and I apologize if I mispronounce your name, Drs. Driver, Prekker, and Freund. It was published in August of last year, 2024, in Academic Emergency Medicine. Now, it's a single-center observational study using a prospective airway registry at Hennepin County Medical Center in Minneapolis. This registry has been used for several other pretty cool airway papers in the past. I am really jealous because they have dedicated research assistants 24/7 in their emergency department, and those assistants collect data in real time during each intubation. And then the operator, who I'm told is almost always a third-year EM resident, completes a data entry form about the laryngoscopy and any perceived adverse events right after the procedure. Now, somewhat uniquely in this paper, they performed a Bayesian logistic regression. Now, they came up with the idea for this study, and then they went back and used the registry to answer the question. In other words, they didn't build the registry just for this purpose because, well, honestly, that'd be kind of silly. They get great data on airway management on an ongoing basis, and then they can use it to answer all sorts of great questions, not to mention aid in their internal quality improvement efforts. We all should have this type of airway registry. And did I mention how jealous I am? I want one of these registries. Now, in this particular study, they include all patients with at least one intubation attempt. They explicitly exclude those with missing data about the sequence of RSI medications, and they also exclude those where only a paralytic is given. Now, it isn't clear from the manuscript if they also excluded sedation-only intubations, and those, if any, were done with no medications, or did they exclude patients who are intubated because of cardiac arrest? Now, I would imagine there would be very few patients in this center that were intubated with sedation only or with no medications who weren't in cardiac arrest, but I can't tell because they didn't explicitly say whether they excluded them. Now, the exposure of interest here was the sequence of sedative and paralytic given prior to the first intubation attempt. That means sedation first or paralytic first, and the approach is what was the exposure of interest. Their primary outcome is first pass failure, not success, but first time failure, and secondary outcome is the proportion of adverse events. So overall, what they're doing is calculating the association between RSI medication sequence and first pass failure. And they sensibly define that as an intubation that requires more than one blade insertion past the teeth. Now, for hypoxemia, they define that as an SpO2 less than 90 in the peri-intubation period. Well, what do they call peri-intubation period? Because this in the literature is all over the place. An attempt at laryngoscopy, that's pretty clear. Did it go past the teeth or the alveolar ridge in our edentulous patients? But that peri-intubation period, really all over the place. Here they defined it as the interval beginning with induction and ending 1 minute, that's 1 minute after laryngoscopy. Now, is that a reasonable definition? Honestly, beats the hell out of me. You got to pick something. That's what they picked. But when you're comparing this to other papers, you got to make sure you understand what that period is. So you're comparing apples to apples. All right, what about their stats? Now, the specific approach of a Bayesian regression is different mathematically than a frequentist regression, but the idea of adjusting an analysis to address potential confounders is not. In this study, they adjusted for age, sex, BMI, and induction agents. Before we jump into the results, let's talk a bit about why anyone might give the paralytic first. Now, we give the paralytic to relax the airway's protective reflexes and maximize the potential for success on the first attempt, or in terms of this paper, to minimize the opportunity for failure. Now, we give the sedative because, well, to be honest, it's cruel and inhuman to force someone to be awake while paralyzed. The issue of the sequence of medications here is all about the onset of action of the drugs. In classic RSI, we want to rapidly induce unconsciousness and muscle relaxation after appropriate physiologic preparation, pre-oxygenation, resuscitation, all the things, but we want to do it rapidly. And the reason is we don't want to have to manually ventilate the patient between the time they stop breathing, and they're gonna stop breathing because paralytics kind of have a way of doing that, between the time that they stop breathing and when you can ventilate again after the ET tube is passed. Now, the idea of not ventilating between induction and intubation, the whole point is to avoid gastric distension and the risk of aspiration. But that would come at the cost of increased risk of pre-intubation or peri-intubation hypoxemia. So this issue of ventilating during paralysis, during intubation, that's kind of controversial, which brings us to the PREVENT trial. And I don't think we've actually talked about it on this podcast, and I feel bad about that. It was a really cool paper. We need to do it sometime. Basically, it was a large multi-center randomized trial of exactly what we're talking about here, ventilation versus no ventilation during RSI. So what did it show? No difference in aspiration. Either suspected aspiration by the intubator, oops, that's gross, that's going to have some aspiration, or on chest x-ray later on in their care. And they did see, though, more hypoxemia in the no ventilation group. So if you feel like you need to ventilate between induction and intubation, go for it. Your patient will thank you. Now back to the rationale for a paralytic first approach. We want the first attempt at intubation to be the best attempt at intubation. The thought is that the paralytic takes a bit longer to work than the sedative does. If you give the sedation first, then the paralytic, well, you'll have a patient who might have respiratory depression from the sedation, but not yet have adequate relaxation. Now, yes, I understand you can argue, and I hear you out there, but ketamine, respiratory depression, doesn't happen. Work with me here. The concept is independent of the type of sedation you're using. But if you give the paralytic first and then the sedative after that, rapidly after that, well, both should have their onset at about the same time. So the respiratory depression, if any, from sedation and the relaxation from the paralytic occur more or less simultaneously. Now, the concept is based on some assumptions that I have issues with, like, say, respiratory depression and ketamine, because I'm all about the ketamine. But we're going to save that for later. Now, for now, that's why some people might advocate for it. And honestly, it's kind of reasonable. I think it's overly complicated. That's just me. But it's probably reasonable. So let's see whether that potentially reasonable approach actually works. Now, after exclusion, they had 2,216 patients for analysis. Most intubations used etomidate, and specifically they're like 89% etomidate, 11% ketamine, so maybe they have to be more worried about that respiratory depression than I do, and I'm all in on ketamine. Now, for paralytics, it seems to be a rocuronium shop, 77% rock versus 23% with sucks. So 57% of the patients got paralytic first, and then obviously the remaining 43 got sedation first. Now their overall first pass failure was 5%. And if you realize that first pass failure is the inverse of what we typically care about, what we typically talk about, that means they had a first pass success rate of 95%, which is really good, and it's definitely higher than is typically reported from emergency medicine and certainly from EMS. Now, raw comparison between the groups showed a higher failure rate with sedation first, that's 5.9%, versus a 4.3% failure with paralytic only. Now, that's an absolute difference of 1.6%. So, 1.6% difference. I'm honestly not sure what the minimum clinically important difference in failure rate is. So I checked out the collective wisdom of PubMed and ChatGPT, and neither one of those bastards could help me find anything published on this. So what did I do? I returned to my group of EMS physician friends, otherwise known as the Guild, and I asked them what they thought about this. Now, most of them suggested either a 5% failure rate. They said, 5% less, 1 in 20 less, that'd likely be the minimum clinically important difference. Now, although my boy Pickett, he suggests a much higher difference. He said it ought to be 20% difference. But he's the white tiger, and let's just say he's special, and I'm not entirely sure he understood the question. So we're just going to stick with 5. And remember, please, that that's just like your opinion, man. It's not like published. This is just what we came up with for the sake of argument, so don't go around quoting it as something official. 5% seems reasonable. Now, even though minimum clinically important difference wasn't used at all on this paper, it is always important to ask yourself if something, even if it's statistically significant, perhaps especially if it's statistically significant, is actually clinically significant. So at least for the Guild, a 1.6% difference in failure rate likely is not clinically significant. Now, having said that, I am all about improving intubation success or decreasing failure, so I'm still interested in the results. Now, please remember 1.6 raw difference, that was not adjusted for any differences in BMI or age or sex, anything else that they adjusted for between these two groups, and that may have been important. Now, fortunately, the authors did report the adjusted odds ratio in their calculation. Now, for the primary outcome of first pass failure, their results showed an adjusted odds ratio of 0.73. That's for paralytic versus sedative first. That means they found 27% lower odds of failure with the paralytic first approach. But you ask, and I can hear you again, you ask what the confidence interval was, because that's what we need to know if that 0.73 was statistically significant. Well, hold your horses here. That question gets us directly at the difference between Bayesian and frequentist approaches. Now, they also found an adjusted odds ratio for peri-intubation hypoxemia of 0.99. Now, let's just skip over the statistical talk. We can all agree that one wasn't really different, regardless of how we measure it. So I'll wrap up the results by saying they also found 77% lower adjusted odds of first attempt failure with ketamine compared to etomidate. Not going to say anything else, just going to point that out. They found 77% lower odds of failure with ketamine. Now, that's interesting because it really contrasts with recent systematic review and meta-analysis of RCTs comparing ketamine to etomidate, and it found no difference between the success rates with ketamine and etomidate. Now, one interesting thing about this paper, this meta-analysis, and it's the one by Greer, Dr. Greer, by Dr. Greer in Critical Care of this year, they found more hemodynamic instability with ketamine, but less need for vasopressor support with ketamine compared to etomidate. Now, I have no clue what to make of that really counterintuitive finding that there's more hypotension but less need for vasopressors. Don't know, but I'm certainly not going to change my practice based on that. Now for some nerdery. Was that adjusted odds ratio of first pass failure of 0.73 that we talked about, the one that said paralytic first had lower failure, was that 0.73 odds ratio, was that significant or not? And that brings us to the major difference between frequentist and Bayesians. Now, I'm sure you've heard Bayesian statistics before, unless this is your first episode of this podcast, because I kind of talk about it, just in passing. But you probably haven't heard of frequentist statistics. And that's likely because you just learned about it as statistics. In other words, it's pretty much the default approach to statistics. Now, if you're interested in the history of frequentist and Bayesians and why frequentist seems to be the default, read the book, this book. I've recommended it before, The Theory That Would Not Die, or, ask the tubes of you for a video. It is a really cool topic. That book, The Theory That Wouldn't Die, it's an easy read. It's really interesting. Thanks again to Rimley for sending this to me. Now, Bayesians don't really think in terms of significance or not. They think in terms of probability. Where the frequentists see a black and white world, the Bayesians see a world of gray and uncertainty, and they embrace the uncertainty. There just isn't significance or not in Bayesian stats, just the probability of something happening. Now, a general summary is that the frequentist approaches are about deciding true or false, while the Bayesians are about describing what you see. Where a frequentist logistic regression would report that the odds ratio of 0.73 for first pass failure was either significant or not, Bayesians instead would report how probable it is that you will see a given result. Now, the cool thing about Bayesian analysis is that it allows you to bring in everything else you knew about the topic before this study. It's with frequentists, this study is the only thing that exists. The results are either true or not. With Bayesians, they bring in everything we know and then add to it to either increase or decrease our certainty about the thing. Now, the last thing I'll say here before diving into how to interpret the results is that frequentist statistics report 95% confidence intervals, where Bayesian stats report 95% credible intervals. Now, these may look the same, but they're really saying two different things, and they should not be interpreted in the same way. That would be a big no-no. They are calculated differently, and they mean different things, no matter how much they look alike. So back to that odds ratio of 0.73. Bayesian analysis said they're going to report a credible interval. Sometimes East Texas just jumps up and messes with my brain. Accents are hard, y'all. I'm trying. They report a 95% credible interval of 0.46 to 1.02. Now, you might be fooled into saying that that interval crosses 1 and therefore it isn't statistically significant. But that would be applying a frequentist approach to a Bayesian result. Poor form, do not recommend, do not do. The statisticians will point and laugh. So the credible interval, it actually says what we typically incorrectly think a confidence interval says. And that is that there is a 95% probability that the true value of the odds ratio lies between 0.46 and 1.02. Now, if that's what a credible interval means, and not what a confidence interval means, then what, pray tell, does a confidence interval really mean? I am so glad you asked. Well, a 95% confidence interval means that if we were to repeat this experiment many, many times with many different samples of patients and calculate a 95% confidence interval each time, 95% of those intervals would contain the true odds ratio. That sounds pretty damn similar, doesn't it? And it's definitely confusing. So here's the key thing to know. Don't interpret a frequentist confidence interval using a Bayesian approach, and don't interpret a Bayesian credible interval using a frequentist approach. In other words, if the odds ratio has a confidence interval, then you're looking for significance, and there is none if the interval crosses 1. Samesies with what we've always learned. That's what we typically talk about because we typically are reviewing papers with a confidence interval that was calculated with a frequentist approach. But if you're reading a Bayesian paper, if the odds ratio is reported with a credible interval, then significance isn't the point, and it would be inappropriate to look for it in the interval. You're looking at the probability of the correct answer being anywhere in that interval. Now, I hope that makes sense. It definitely took me a few passes through it to begin to wrap my head around it. And because I am rather math challenged, and statistics is kind of a branch of math, it takes me going over and over it to understand it. So the differences are subtle. Just look for that credible interval versus the confidence interval. So now that you know not to look for significance in a credible interval, well, how are you supposed to actually use these Bayesian things? And why do people think it's helpful? Well, because that credible interval, it's a range of where we think the true odds ratio lies. And from that range, you can calculate the probability of the true odds ratio being at least as great or greater than any point you're looking for. Now, in this paper, they calculated that the probability that the odds ratio was less than 1, meaning first pass failure rate, was lower with the paralytic approach, the paralytic first approach. And they also calculated the probability that it would be less than 0.9. So they calculated two probabilities. And what did they find? Well, they found a 96% chance based on this and prior evidence that the failure rate was lower with a paralytic first approach. And they found an 88% probability that failure rate was at least 10% lower odds, meaning the odds ratio is less than 0.9. So while there is no black and white answer, there is no comforting but potentially misleading p-value, there is a level of certainty. What's that certainty? Well, we're pretty damn sure paralytic first approach is at least a little better. And if you wanted to report on the probability of seeing at least the minimum clinically important difference, you could do that too, and I would certainly understand why you would want to. Now, we can't get there from what they reported, or at least I can't. I don't know how to do it. Don't think you can. Maybe I'm wrong. I can't. But let's just say they set up the study, because I know you can do it going forward. Let's say they set up the study to calculate the risk difference instead of the odds ratio, just the absolute difference between the risk of failure. Then we could use the resulting distribution to calculate the probability of seeing at least the minimum clinically important difference, based on the guild's guess anyway, of 5%. So just for the sake of understanding how to use this information, how you would apply the results of this study, what would you do if I told you, now I'm making this up, but what would you do if I told you there was only a 30% probability of a paralytic first approach resulting in the minimum clinically important difference, or maybe even more? Well, I don't know about y'all, but I wouldn't think a 30% chance was very good, and I probably wouldn't change my practice. Now, keep in mind, I just made up that 30% thing, just like the guild made up the 5% threshold for the minimum clinically important difference. I can tell you, by the way, that the way you create a minimum clinically important difference is by getting a bunch of subject matter experts together and getting a consensus. So the reason 5 is made up is just because there were a small number of people and we didn't do it formally. Concept is the same. Now, just because I made up these numbers, I did it for the sake of describing how we can use Bayesian approaches. And even though I can't calculate the actual probability of a meaningful difference, the difference they found was 1.6%. So even without nice posterior probabilities, I'm guessing the odds are probably fairly low. So what did this study do? It told us there is a very high chance, like a 90% chance, actually a 96% chance, that paralytic first is associated with at least some improvement in failure rate, even though it isn't very large. And I'm not sure, given the potential risk of awareness with a paralytic first attempt, and definitely the added complexity of assuring the timing of the sedation administration isn't all mucked up because we got confused. Given that, I'm not sure I think it's enough to change my practice. Now, I will say that a prior paper suggests that this risk of awareness, giving the paralytic first, wasn't very likely. That was a driver paper done by the same research group out of Heideman. And it probably isn't very high, but the complexity of the process and the opportunity to mess up how long it takes you to give the sedative, that's what bothers me. So that's the results and how to interpret the Bayesian credible interval and how to decide whether you think you should change your practice. So for me, I'm not changing my practice based on this. Why not? Well, because I think there's a better way to minimize failure than giving the paralytic first. If you think about it, the only potential way a sedation first approach would result in a higher failure rate is because the paralytic hadn't had a chance to fully relax the patient yet. And by giving it first, you might get maybe an additional 15, 20 seconds for it to take effect. But, just hear me out here, but what about instead of changing the order of the drugs, you just wait an additional 15 seconds to intubate? I mean, practice some patience here. Let the paralytic work. But what about hypoxia, you say? Well, give them gentle manual ventilations. You have the BVM there for a reason, and the PREVENT trial showed less hypoxia and no additional aspiration risk with ventilations. So just be patient and bag them if you need them. Now, we know that humans are really bad at estimating time, especially when they're under stress, like when intubating a sick patient. So what's my solution to this? Well, use a timer. Use your watch, because your watch doesn't get stressed. It's always accurate. It's why we put a timer here in Fort Worth with our laryngoscope, and we mandate its use with every intubation, specifically to assure that we're giving the paralytic time to optimize intubating conditions. The first attempt needs to be the best attempt. Oh, and the most important reason that I'm not going to change my practice based on this paper, universal DSI. We do DSI on everybody. I do DSI on everybody. I don't see a downside. All I see is upside. That negates the entire question because you're given the ketamine several minutes in advance of the paralytic so that you can assure your patient has been maximally preoxygenated or denitrogenated. Now, despite this paper not giving me exactly the answer I wanted, because I really wanted the absolute risk reduction instead of odds ratio, and despite it not changing my practice, I actually really like this paper. I think it was well done, it was reasonably well written, and I love that they used a Bayesian approach. I hope this little return to the Valley of the Nerds to talk a bit more Bayes was helpful. I really struggled understanding the difference between confidence intervals and credible intervals until I did a deep dive into this. I am really thankful for those of you still listening to have the opportunity to share what I learned. Now, as always, I'd love to hear your thoughts and comments. Especially, I want to hear your comments if you're a statistician who's been twitching listening to this and you desperately want to say, actually, and tell me how much I've massacred this, please reach out because you're probably right and I would like to learn. So you can get me on Blue Sky at drjeffjarvis.bsky.social or on the platform formerly known as Twitter at Dr. Jeff Jarvis. Now, if you're a social media Luddite, and if you are, you're probably much less neurotic than I am right now because of it, you can always email me at jeff.jarvis@flightbridgeed.com. Thanks for listening. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.